Welcome to Continuing Mobile Education for Emergency Medical Services Providers. This is Special Considerations, Episode 1, Fevers in Newborns. After viewing this episode, participants will review the newborn's immune system. Participants will also review fevers in the newborn and why they are concerning. Finally, participants will review the pre-hospital management of newborns with fevers.
Recently, I encountered a young patient about 4 to 5 weeks of age that was actually a twin that had run a fever. The parent didn't recognize the importance of it, figured it would self-resolve, and it ended up being a point of chronic dehydration over a couple of days, and obviously the younger child can't sustain that kind of fluid loss and turned out to be quite acutely ill. So the recognition of fever by parents as well as EMS providers is very important.
The child, for the first 2 to 3 months of age, really the immune system is only based upon what was transmitted to the baby or given to the baby via mom through transplacental transport of the gamma globulin transplacentally to the baby. So in essence, what mom has been exposed to, the baby will be somewhat immune to passively. There is minimal to no active immunization for the first few months of life, which is why the first, especially 2 months, but possibly even up to 3 months, children are very vulnerable to developing infections and being overwhelmed by them because their immune system is somewhat immature and they're not actually able to mount a full-blown immune response when exposed to infections that mom has not given immunity to.
The important thing with identifying fevers with pediatrics, especially the younger ones under 3 or 4 months of age, is the recognition of underlying medical problems. Particularly in that age group, the immune system isn't quite developed yet, neither is their thermoregulatory system. So when there is a presence of a fever, it needs to tip you off as far as underlying medical problems, viral illnesses, among them that causes the fevers. But they need to be taken seriously because a lot of infections with kids, especially the younger age, don't present with fevers. So you still need to keep the index of suspicion high in those cases. But certainly, but the presence of a fever should be taken seriously, especially for the younger pediatric patient. As far as identification of underlying illnesses.
The newborn's immune system is immature, has a limited ability to fight infection, and an immature thermoregulatory system. Fevers are often associated with underlying medical conditions, thus you should have a high index of suspicion.
The most common cause is still the run-of-the-mill viral infections, which we would not be terribly concerned about. Unfortunately, approximately 8% or 10% thereabouts, they can get bacterial infections. The most common are the infections that mom transmits to the baby as the baby's being traveling or traversing the birth canal, such as Group E strep, E. coli, Listeria are some of the more common bacteria. Again, as we had sort of alluded to in the earlier question, is because these children often don't have any immunity whatsoever to these bacteria because the mom has not transmitted any immunity gamma globulins to the baby. These babies are particularly vulnerable to not being able to fight these infections, and they cause infections of the meninges, of the joints, of the lungs, of the heart with bacteremia, and if not treated, recognized and treated aggressively, these children can succumb within hours.
Probably one of the most common presentations you'll get for an ambulance call for a kid with a fever is a kid who has a febrile seizure. And most of those kids are children who don't have a seizure disorder, but based on how rapidly the temperature changes, not how high the temperature goes, the child has a seizure, which is quite a frightening event for the child, for the family. Most kids who have febrile seizures, it turns out to be a relatively benign event for them, though it is very frightening. There are some special populations that fever is really of a concern. Patients under 3 months of age with any report of fever need to be seen at a hospital. Patients with sickle cell disease who have fever, and then those patients who are in a cancer population or maybe having some hematological problem, oncology problem that makes them predisposed to getting infections.
Well, like was mentioned before, the presence of a fever is certainly a red flag that there's an underlying illness creating the fever. The immune response, again, is suppressed in the pediatric age group, especially in the younger ages. And so it's important not to miss these presence of underlying illnesses and the risk of the infections, or a septic patient being unrecognized when in the absence of a fever is certainly a potential as well. So you're looking for things that go along with fever type of activities, such as restlessness, agitation, sleep-wake cycle aberration, things that might indicate that there's an underlying illness, whether the fever is present or not.
Fevers are often a sign of bacterial or viral infections. They can be transient due to the immature thermoregulatory system and are definitely a potential life threat. The young and the immune compromised are at high risk for infections.
Pre-hospital management is still going to be the old, tried and true, recognize and manage airway issues, recognize and manage breathing issues, and then obviously circulation. I often put the D and the E. The D for disability, often with trauma, but you're talking about a medical issue in this situation when you're referring to fever. And D should remind pre-hospital care providers to think about dextrose. These kids are often and universally we have to have a concern of being hypoglycemic. And then E is environmental, which in the extreme child, a child in extremis, or when you're concerned about a febrile septic child, is make sure that their body temperature is kept somewhat close to normal, again, 37 degrees Celsius. We prefer them not being cold, especially if the child is exposed to the elements, so to speak, but making sure that children stay warm. We do know very, very well that children who are hypothermic have longer hospitalizations and more difficult, complicated hospitalizations. The other thoughts, again, we're not asking pre-hospital care necessarily to get blood tests. In fact, if it's not necessary, we're not even asking them to start IVs unless there's an aberration noted in the ABCs. Obviously, if the child is shocky, not well perfused, as manifested by decreased capillary refill, decreased mental status, decreased urine output, cool, dusky extremities, weak central/peripheral pulses. If obviously that's seen, then IV access would be important. Otherwise, we would get IV access in the ED, during which time we would draw blood cultures, etc. But really, it's primarily to recognize and address the airway, breathing, circulation.
Well, recognition is certainly a key, as I mentioned, a red flag that there is something going on as far as an underlying illness that's significant enough to trigger a fever response in the pediatric patient. Certainly the routine medical assessment of the patient, history, present illness, and not just for that acute period where EMS was called, but also the 24 or 48 hours preceding that by the primary caregiver, if available, can certainly lead you on to the right path as far as what might be presenting problems, such as wetting of diapers, food and fluid intake, bowel movements, things like that might not be available from the person who actually called EMS, but that information certainly vital and may be available from a primary caregiver that could give you more information. So history is really important from the people at the scene, because those people that information might be lost once you get to the hospital.
In pediatric patients, probably the best things you can do are to keep them comfortable and calm. You want the parent with you or somebody that the patient trusts in their eye view, but it's also important that you transport them safely using a car seat or the gurney and not sitting on somebody's lap. Depending on what's causing the fever, if the patient's immunocompromised, you got to make sure you're not giving them anything also. You kind of isolate them, you wear a mask. A lot of it's comfort measures. As EMS providers, we don't carry Tylenol or Motrin to bring the fever down. But these patients may have chills, and any other symptoms that you can do something about, you should, to try and make them as comfortable as possible for transport.
Managing fevers includes the ABCs: dextrose for a potential hypoglycemic event, maintaining temperatures, a detailed history of the past few days, and keeping the patient comfortable and calm. After viewing this episode, participants will review the newborn's immune system. Participants will also review fevers in the newborn and why they are concerning. Finally, participants will review the pre-hospital management of newborns with fevers.